Hello guys, welcome to this video, and today we are going to study periodic health examination from Family Medicine Toronto Notes. So let me tell you guys, for mccqe1 we do have an objectives on MCC websites, specifically on periodic health encounter. If you click medical expert, you can see medical objectives there, and if you go into the section P, you can there see a periodic health encounter preventive health advice. This is the objective that I'm going to teach you today. So let's get to it together. So the rationale of this objective is what you need to know exactly is a periodic health encounter preventive health advice session represents an opportunity for the prevention or early detection of health related problems. The nature of examination will vary in timing and frequency depending on the age, sex, occupation, psychosocial background of the patient. The encounter may take the form of an in person visit, electronic phone encounters, or delegated acts by other healthcare team members. So, this is telling you what exactly a periodic health encounter is, and it depends on the age of the person, the sex of a person, the occupation, and the psychosocial background of the person. So, it can be tailored according to that, right? So, let's see all ages. In all ages, we will talk about injury prevention, noise control, seat belts, bicycle helmets. In lifestyle modification, we'll talk about physical activity, smoking prevention, cessation, sun exposure, immunization, and there's an additional immunization objective that they mention here 72 74-2 is the number of the objective. So you need to know how they are teaching you and how they want you to learn, right? So make sure do not confuse yourself with these numbers mentioned here. Just want to tell you that this is a number of objective, okay? So you can go back and see if you want to see that, okay? Infant and child, you will talk about nutrition, growth, development, behaviors, hearing, and amblyopia. In adolescence, you will talk about sexual activity like contraceptions, STIs. In younger adults, you will talk about if she's a female, you'll talk about pap smear, STI screening, and folic acid. And if it's a middle aged adult, you will talk about blood pressure, blood glucose, lipid profile. And then also after 50, you start talking about the cancer screenings, specifically breast cancer, colon cancer, prostate, and skin cancers. Also, you will check for osteoporosis in patients who are in the middle age. And then for older adults, you will talk about fractures and fall preventions, osteoporosis screening, which is BMD. And then you will talk about nutrition, dementia screening, and cognitive screening. Okay. Now, what are the key objectives? Given a patient presenting for preventive health encounter, health advice session, the candidate will determine the patient risk of age and age specific and sex specific in order to guide history, examination, screening, investigation, and counseling. So you need to know the history and examination part. You need to check for appropriate investigations in the patient. Let's see evidence-based screening investigations specific to age and sex. So let's say fasting glucose mammogram. So I could recall, let me just tell you how we can get a question in QE1 regarding periodic health visit. A 40-year-old male coming in for blood pressure checkup. His blood pressure is normal. He exercises every day, and he smokes 2 cigarettes every day. He's overall doing well. What else are you going to talk to that patient about? So he's a 40-year-old male. He is healthy. His blood pressure is okay. He's smoking 2 cigarettes per day, which is something that you can definitely talk to him about. Additionally, you will also talk to him about his blood work. You will check his blood glucose levels. You will check his cholesterol levels. Why? Because number one, he's 40-year-old. Number two, because of his age, his risk factor of smoking, and then screening about his family history as well. So age specific is something very, very important in periodic health visit. Okay. Now we will move on to the Toronto notes part of the periodic health examination. So Canadian Task Force on Preventive Health Care was established in 1976 to develop and disseminate clinical practice guidelines for primary and preventive care. You don't need to remember the date. Recommendations based on systemic analysis of scientific evidence, periodic preventive health visits are recommended instead of annual physical examination. So this is something that you need to know, that in Canada you usually prefer periodic health preventive health visits, where you frequently see the patient and you talk to them about preventive health visits rather than just seeing them once yearly and just doing everything together. No, it's better if you do periodic health examinations. On the right side, we see a small box which says Adult Periodic Health Exam. Male and female evidence-based preventive health checklist forms are available online. So you can go and see on this website for your reference, like what exactly do you do in male and then female, and compare them both and see the differences between them. Okay. Now, what is the purpose of periodic health visit? Why do you want the patient to come and see you every 3 months or every 6 months? Primary and secondary prevention. What is primary prevention? Make sure. Remember, always remember these with the examples they give you. Primary prevention is vaccinations. What is secondary prevention? Is the screening program. So, what is the difference between both? Primary prevention, you do it for a kid with no risk factors. You know, he has a history of family diabetes. He has a lot of histories in his family, but it runs in, like, let's say after 50 years of age. But for a child, you will just do vaccinations because that's where you're preventing the child from having that infection, like measles, rubella, chicken pox, flu shots. You can do vaccinations for, let's say, tetanus. So all those things are primary prevention. Secondary prevention is once the patient has reached that age, you start doing screening programs. So that means that same child, when he reaches the age of, let's say, 50, you're going to start doing colonoscopy, you're going to start doing fit test, FOBT, you're going to start doing, let's say, if she's a girl, you're going to start doing mammogram. So that is called as secondary prevention. So remember the examples and you will never forget what is primary and what is secondary, okay? So let's go through it together. Identify risk factors for common diseases, counsel patients on health promotion practices. Secondary prevention is early detection of the disease to allow prompt treatment and to prevent the disease progression. So early detection and preventing the disease progression, okay? So detection is screening, which is secondary prevention. Primary prevention is vaccination. Now, this is a great classification of recommendation. You don't need to go through that. That's fine. High evidence, moderate evidence, and low evidence. That's fine. Ignore this. Moving on to the right box, choosing wisely Canada. I would recommend every one of you who's going to do QE1, make sure you go through this website, choosing wisely. You can, the best way to go through this website is doing it chapter wise. If you're doing, let's say, family medicine, so make sure you go through that. Let me just open that for you as well. Let me just open that for you, and then we will see how you have to cover that. Okay, choosing wisely Canada. So let's say you have opened this website, and now on the right corner you see this. Now you go to the recommendations. In the recommendations you see everything. Now we're doing family medicine. Let's do quickly family medicine. So these are the recommendations. There are total 14 recommendations that we can quickly go over. It says don't test urine in older patients with a change in mental status unless there is a clear evidence of infection. And if you don't understand why, then you can read this. Treating asymptomatic bacteriuria does not improve clinical outcome but may increase the adverse event from 1 to 7% in older patients with asymptomatic bacteriuria and altered mental status. Antibiotics should be avoided without clear signs and symptoms of infection. So at times we do treat asymptomatic bacteriuria in pregnant patients, but they are telling us not to do urine test in older patients because why? We would incorporate more antibiotics that could deteriorate their mental status. So it's better to clearly make a diagnosis and then incorporate antibiotics in an elderly population. Okay, so that's one of the recommendation. They could test you on this. Don't initiate opioid long term for chronic pain. Recommend and help support physical activities as a foundation for managing osteoarthritis and chronic low back pain. One of the QE1 question that they could ask you, that because they don't want the doctors to prescribe opioid treatments in osteoarthritis because it's gonna come in by age 50 or 60. So it's good if you emphasize, if you're a good doctor, you would emphasize on a physical activity, managing osteoarthritis with multidisciplinary approach rather than just going straightforwardly to opioids, right? Opioid use in osteoarthritis and low back pain beyond 4 weeks duration did not show statistically significant more responder than placebo beyond 4 weeks duration, suggesting them short-term benefit may not persist. Opioid also demonstrated a high risk of adverse event, including number needed to harm of 8 to 10 from withdrawal due to adverse effect. No include trials. So basically they're telling you that exercise based programs show meaningful pain relief in patients with low back pain and osteoarthritis compared with control. So it's not good to go opioids. Why? Because patient would have adverse effects related to withdrawal. So it's good if you go on non-opioid options. Don't continue opioid analgesics beyond the immediate post-operative period and other episodes of acute severe pain. The immediate post-operative period and acute episodes of pain typically refers to a time period of 3 days or less, and rarely more than 7 days. Prescribe the lowest effective dose and number of the doses required to address the expected pain. This recommendation does not apply to individuals already on the long term chronic opioid. I've seen a lot of patients going through knee replacements, a lot of replacements, and then stay on opioids, and then they are addicted to opioids, and then now it's difficult for them to wear off the opioid. So it's good. The recommendation is to keep them on a short term courses, 3 days or 7 days, not going beyond. Okay. Don't do annual physical exams or on asymptomatic adults with no significant risk. You see, one of the things that we were just talking about, the annual physical health exam for asymptomatic people have not been shown to decrease mortality, change blood pressure, body weight significantly, nor change smoking status. Preventive health visits used by many family physicians increase uptake of preventive health interventions like pap tests, colon cancer screening may decrease patient worry. Other means of achieving cancer screenings are being implemented by various prevention programs. So you don't do annual physical exams on asymptomatic adults with no symptoms. So it's good if you stick with the guidelines, age appropriate guidelines, perfect for your practice. Okay. Don't order dual extra DEXA screening for osteoporosis on low patients. Use risk assessment first screening before ordering DEXA. So there's a chart in Toronto Notes that we will definitely go through for osteoporosis. Even there's, I think, this chart in family medicine that we'll go through. So they're recommending to go through that guideline and approach rather than directly ordering the DEXA scan for low risk patient. So you will go through that. Okay. So screening may help reduce the risk of fragility fractures in females over 65. The task force recommend risk assessment first, screening for females aged more than 65. Use the results of the Canadian clinical FRAX risk assessment is the tool that we usually call for before doing BMD. At this initial assessment, BMD measurement is not required. So for low risk patient, let's say a patient who's 50 years old coming in with pain, she doesn't she was not on steroids, she was not having any family history, she's all good, she's doing healthy, no functional changes. So you don't need to do any kind of DEXA. You can just manage her symptomatically, and if the pain doesn't resolve, then we can think about it. Okay, so you have to have a approach. After this discussion, if the preventive medication is being considered, perform BMD, then recalculate fracture risk by adding the BMD T score into the FRAS. So there is a recommendation, we'll stick with that for osteoporosis. Okay. Don't advise patient with non-insulin dependent diabetes to routinely self-monitor blood sugar. So if the patient is not on insulin, there's no need to monitor sugar. Routine self-monitoring of blood sugar in type 2 diabetes who do not use insulin has no clinical benefit. It is not cost effective and reduce the quality of life. Its use in the patient with type 2 diabetes using insulin and those with gestational diabetes may be individualized. Though many suggest using it in the patients with newly diagnosed diabetes, there is no evidence of improved glycemic control and it may increase depressive symptoms. So they are not recommending the type 2 diabetes patient with on insulin. You recommend monitoring blood glucose levels. But if the patient is not, let's say, on insulin, is just using metformin, you would not recommend them to monitor blood glucose sugar. Why? Because it was increased depressive symptom. The sugar goes high, patient would be sad. So it's good not to monitor it every other hour. It's for patients on non-insulin dependent diabetes. Don't screen for thyroid dysfunction in asymptomatic non-pregnant adults. Definitely, if they have no symptom, you don't need to treat. That's a general rule, okay? Irrespective of thyroid. Don't do imaging for low back pain unless red flags are present. Red flags include, but are not limited to, severe progressive neurological deficit when serious underlying conditions such as osteomyelitis are suspected. Imaging of the lower back spine before 6 weeks does not improve outcomes. So now here I would discuss the practice that we usually do in the clinics. Number one, if the patient is coming in with low back pain, you need to screen for urinary incontinence, numbness, tingling going down the leg, if the pain is radiating down the leg, if there is any urinary or stool incontinence. So these are kind of red flags that you need to consider. Or there's a history of trauma, there's a history of osteoporosis. These are the kind of red flags that you would consider and you would want to do the x-ray, right? But if there's no such things, there's no point of doing it unless you treat the patient for 6 weeks. Don't use antibiotics for upper respiratory tract infection that are likely to be viral in origin, such as influenza, like illness, or self-limiting, such as sinus infection, or of less than 7 days of duration. So centers criteria is the one that we usually applies here. So this is a talk of the town. No antibiotics for viral infection. How do you differentiate? Number one, you should be aware of that. Runny nose, cough, coryza, all those flu-like symptoms, that's viral. And even that, if that is for less than 7 days. So that's definitely viral. And if everybody around the house is having the similar kind of symptoms, probably viral. If there's a mucus coming up that's green in color, that brown in color, then probably this is bacterial. And if the patient has been having these symptoms for more than 7 days, then probably a bacterial. Then you would give antibiotics. Don't order screening chest X-ray, ECG for asymptomatic low-risk patients. So there's little evidence that detection of coronary artery stenosis in asymptomatic patient at low risk of coronary heart disease improve health outcomes. False positive tests are likely to lead to harm through unnecessary invasive procedures, over treatment, and misdiagnosis. So there's no point of doing X-rays and ECGs for asymptomatic patients. Don't screen with pap smear if under 25 of age and over 69. So after 69 or 70, we stop doing pap smear, and under 60, for 25, there's no point of doing it, right? So don't do annual screening blood tests unless directly indicated by the risk profile of the patient. So usually we don't do blood tests unless it is required. You usually start blood testing the patients for lipid, cholesterol, glucose after age 40, right? So there's no point of doing that in asymptomatic patients. The vitamin D recommendation is currently under review, so we need to review that. I remember there was a recommendation not to test and just to give the dosage, but now there it's under review. So don't conduct in-person visits where virtual assessment would provide equivalent clinical values and is preferred by the patient. Applies where fee structure exists to compensate for virtual care. So it's recommended that you can do a remote monitoring of chronic conditions, and then that is fine. If it's safe, you can go ahead with that. So it's something that a doctor can consider doing, right? So these are the recommendations related to family medicines. Once you complete that, go back, and now you know that every topic that you're gonna do, you will read their recommendation. So luckily we're able to do the family medicines recommendation. Now we'll go back to the periodic health exam. So choosing wisely, family medicine is done now. Now moving on to this table. This is a very important table. Let's see. So what are we gonna? These are basically a components of periodic health exam that you're gonna do in when a patient comes in the clinic. For general population, it applies to everyone. Dental hygiene, community fluoridation, brushing, flossing, noise control, hearing protection, screening for poverty, smoking counseling, nicotine replacement therapy if the patient is smoking, referral to smoking cessation program. So let's say everything is good in a 35-year-old male who's coming in clinic for periodic health visit and he just smokes. So what are the three things that you're going to recommend? Number one, smoking cessation, counsel on smoking cessation. Number two, a referral for smoking cessation program and offering nicotine replacement therapies. Okay, so remember these things by heart. Dietary advice on leafy green vegetables for everyone. Seatbelt use for everyone, specifically for children. Moderate physical activity and avoid sun exposures and wear protective clothing. Problem drinking, screening, and counseling. Counseling to protect against STI in adolescents. Nutritional counseling, dietary advice on fat and cholesterol, dietary advice on calcium and vitamin D in elderlies. Okay, so now patient special population related for pediatric population, you would check for home visits for high risk families. Who are high risk families? If you think the child could be going through abuse, you usually do reporting it to the child protective service, but this is one of the things that is mentioned here. Injury prevention, poison control, smoke detectors, non-flammable sleepwears, hot water thermostat settings, inquiry into developmental milestone. So make sure you remember all these examples written here. Poison controls, how would they ask you? They can ask you in an MCQ that the child is brought up by a parent, and now the child has some bruise on the thigh, let's say, and you when you were examining and when you asked the mother, she covered and said maybe he burned himself or something like that. So you need to check. It could be hot water thermostat settings in the house. So these are few of the things that you need to be aware of, right? Inquiry into the developmental milestones, and then coming into adolescence age group, counsel on sexual activity, contraceptive methods, counsel to prevent smoking initiations, and substance use. So for adolescents, you need to remember three most important things: sexual activity, substance, and smoking. Perimenopausal, more than 50, assess for risk factors of osteoporosis. Fractures, counsel on osteoporosis, counsel or risk benefits of hormone replacement therapy. Three things are here again: osteoporosis, counsel, and risk factors, and then hormone replacement therapy. For adults more than 65, follow up on the caregiver concerns for cognitive impairment and multidisciplinary post-fall assessment. So post-fall assessment and cognitive impairment. Okay. Now, for physical examination, if a patient is coming in, you need to take blood pressure measurement, especially all the vitals. You're gonna take height and weight and BMI of the patient for more than 18 years, and then you also for pediatric population, you will examine hip, eye, hearing. So for hips, you are looking for Ortolani's and Barlow's test. You're looking for any developmental dysplasias of hip or femoral dysplasias, that kind of problems. And then also if you move into eye, so you see if there's any problem with let's say red reflex is absent, or there's a presence of white reflex, looking for retinoblastoma or any kind of thing. And then for hearing, you will check if there's any kind of hearing problem, behavioral disturbances, patients with, let's say, autism spectrum disorder. Ruling that out is one of the most important things. So you do hearing tests in that case as well. So especially in the first year of life, you see eyes, hearing, and then hip. In the serial, height and weight and head circumference, and then you go ahead and do visual assessment after age 2. So after 65, you would check hearing impairment in the age 65 and more as well. Inquiry, whispered voice test, and audioscope. First degree relative of with melanoma, you need to check full body skin exam. Okay, so this is something that we usually practice in clinic. Whenever a patient is coming in for periodic health exam, we make sure that we have a look on the skin on the back, around the ears, around nose, everywhere we do see. And if there's any suspicion of a irregular mole or irregular lesion on the skin, we make sure that we send the patient to dermatologist. Now moving on to the test. What test do you recommend? See recommendations below for age and gender specific screening for diabetes, dyslipidemia. So we'll specifically do it separately in family medicine. So I'll go through those as well. And then one time screening ultrasound for abdominal aortic aneurysm in men age 65 to 80. So you need to remember the ages because they may test you on exam on specific age group and see if you know or you can recall the age groups. So 65 to 80, one time screening for abdominal aortic aneurysm. So for pediatric population, what do you test? You test hemoglobin for high risk patient and blood lead screening for high risk infant. So who are high risk infant in hemoglobin? Patient Africo-Caribbean population, a child with a family history of sickle cell anemia, you would check his hemoglobin. And who would you test for blood lead screening? You would test someone who's living in an old a house built before, let's say, 1950s, and it's an old building. And in such cases you will definitely, and having a history the parent does give a history of low socioeconomic status, living in poverty, is unable to meet the ends. So these are the kind of situation where you're going to test the child for blood lead levels. Also, TB high risk groups, you're gonna check Montauk skin test. Who are high risk groups? People who has recently traveled, immigrants living in a congested area, congested community setting. So that's TB. STI high risk is voluntary HIV antibody screening. Patient is coming in themselves and asking you to do STI testing. Gonorrhea screening, chlamydia screening in women, syphilis screening, gonorrhea, chlamydia, and syphilis and HIV. So I have made a video on STI testing previously as well. So if you guys want to go and check, make sure you check because that was from the latest guidelines and some website references as well. And then syphilis high risk group, VDRL testing is another additional thing that you do. So what is the difference between VDRL testing and the specific test? So VDRL is basically a screening test for syphilis. Therapy wise, folic acid supplementation for women of childbearing age, definitely. Pharmacological therapy of blood pressure according to CHEP guidelines. Varicella vaccine for children age 1 to 12 and susceptible adolescents adults. Rubella vaccine for all non-pregnant women of childbearing age, unless there is a proof of immunity via immunization recorded serology. So rubella vaccine, varicella vaccine, pharmacological for hypertension, folic acid for pregnant women or childbearing age, and then tetanus vaccine routine booster every 10 years if had a primary series. So we'll go through that in the plastic surgery as well. Now, pertussis vaccine in less than 65 should receive one booster given as Tdap, Adacil, Boostrix, and herpes zoster for more than 50 years. So usually, herpes vaccine is usually given after 50 years of age. Government usually covers it for you if you're more than 65. There are two doses 6 months apart. So that's how you usually do it for herpes. Okay. So, therapy wise, special population wise, pediatric routine immunization, we have a card, a yellow card in the office that we usually give to the parents, and they follow it accordingly. And then influenza high risk group outreach strategies for vaccinations, annual immunization, now recommended for all. So, influenza is basically the flu shot that everybody gets every spring. So, that can be given to all ages of, patients from all ages. HPV is usually vaccination for males and females from age 9 with no upper limit if ongoing risk. So I recall a case where there was a girl who was curious to know if she can get an HPV vaccine. So if she's 9 plus, or even a male, if he's 9 plus, he can get HPV vaccine. Okay. TB high risk age group, isoniazid prophylaxis for household contacts or skin test converters, isoniazid prophylaxis for high risk subgroups. So any case who is exposed to TB, you can give isoniazid prophylaxis. Immunocompromised, age more than 65, COPD, asthma, congestive heart failure, aspenia, liver or kidney disease or diabetes. So you need to give pneumococcal for all more than 65 or high risk, and add Prevnar 13 for more than 65 and high risk. So you need to learn for Prevnar and pneumococcal. There could be a confusion amongst you. So let me tell you, if the patient is, let's say, immunocompromised, he is more than 65, he has COPD, or let's say any chronic condition he has, you need to give Prevnar 23, Pneumovax 23, which is recommended for all more than 65. Add Prevnar if the patient is more than 65 and high risk. Okay, so if patient is more than 65, you have to give Prevnar 13 along with Pneumovax 23. So you usually give to high risk, you give Pneumovax 23, and if the patient is more than 65 and high risk, you would give Prevnar 13 as well. Okay, so these are the recommendations for periodic health exam. Make sure you follow it. There are few things on the table that I would want you to learn by heart. Number one is the immunization part for the elderlies and immunocompromised. Then the HPV vaccine part for the young patients, STI screening for the young patients. For pediatric, I would emphasize on the discussion part where they tell you about home visits, smoke detectors, poison control. So that's that. And then, yeah, I think that's about it. There's one more last table on the right corner for folic acid supplementation in pregnant patients to prevent and neural tube defects in all women capable of becoming pregnant. Low risk women, no personal health risk, planned pregnancy, diet of folate rich food, and daily oral multivitamin supplementations contain 0.4 1 milligram folic acid for at least 2 to 3 weeks, 2 to 3 months before conception throughout pregnancy, and add 4 to 6 months postpartum as long as breastfeeding continues. So usually start 2 to 3 months before pregnancy, and then 4 to 6 months after postpartum or until breastfeeding continues. And this the dose is 0.4 to 1 milligram for low risk women. They don't have any risk factors, they're taking good diet, they're all good. You start, okay? For high risk women, who are high risk, they have health risks including epilepsy, insulin dependent diabetes mellitus, they have BMI more than 35, family history of neural defect, high risk of ethnic group, so diet of folate rich, and daily supplementations with multivitamins or with 5 milligrams of folic acid. Usually we're giving 0.4 to 1 milligram. For high risk, we're gonna give 5 milligrams at least 3 months prior to the conception until 12-week post conception. From 12-week post conception until postpartum period, 4 to 6 weeks, as long as breastfeeding continues, you can bring her down to 1 milligram or 0.4 milligram of folic acid is sufficient. Women with additional lifestyle issues, poor compliance with medications, no consistent birth control, taking possible teratogenic substances, higher folic acid doses of 5 milligram, counseling about prevention of birth defects. So this is where you can be questioned, or maybe you can be tricked in a way that they may give you a situation where there is a high risk factor, and they want to see if you can pick up that high risk factor in the age. So make sure you know the high risk factors: epilepsy, insulin dependent, diabetes, BMI more than 35. BMI more than 35 is one of the very common one that they can give you in the case. Family history of neural tube defect, high risk ethnic group. So these are few of the things that you can recall. And yeah, I think we're good on that, so we'll proceed to the cancer screenings and rest of the part on the family medicines health promotion in the next video. So I hope you like the video. Please subscribe to the channel and support me if you like such videos and you want me to continue making such videos. Yeah, thank you so much and good luck with your preparation.